lectures, this session. Uh, I think we've all seen that quality of life is becoming a big part of doing what we're focusing on. So our role really on the patients is not simply to just fix a defect, but really try to. All right. So Dr. Dr. McGamble is she's wasn't available. Um, so I'm going to give a really brief introduction based upon this topic. So, quality of life and hernia really become a significant interest of mine moving forward, and I was brief what our interest is in this topic. So hernias are debilitating pathology, and there's a significant hit when you talk about what about pathology. I think we're hernia for the most part is really becoming a significantly chronic. And when we say a chronic life moving forward, I realize that even when we put mesh in patients, looking 5, 10, 15 years out, we're starting to note that they have significant issues and complications moving forward with their lives. So when we talk about quality of life, and we talk about specifically also meshes, it's meshomas that can form hernia recurrences. But then don't forget these patients also have other things that go on left in them. They have other surgeries. They get adhesion instructions. All these are issues that resonate from the placement of patient. And I think for the most part, quality of life. So when we start talking fixing the defect, we want to talk about their life in terms of longevity. You know, what's going to happen 10, 50 years from now. So, this is a great quote. Natural history of abdominal hernia is that with time, a patient's quality of life will work. Right? And it does. I mean, it does. I mean, patients are of complex abdominal wall reconstruction and bariatric surgery. You know, I kind of feel like I'm almost I'm a surgeon's lesson in a lot of terms of what we do. And these hernias are debilitating. Right? These patients, their function is poor. You know, they can't live with things. They can't bend. Not fixing them really, significantly worsens their outcomes in terms of quality of life. So I really did a quick intro of why this is an interesting topic, and I honestly look forward to our fantastic speakers that we put together. Kind of look at where quality of life is kind of percolating up in the world of hernia. This was for females. Most of the hernias, they were a combination of insumoles, and you can see in terms of like quality of life, there's so many different effects, right? Like their exercise is affected, eat and what their diet changes are is how it's affected. Change how they eat because they have pain from daily activities. Even their sexual patterns are changed, right? There's body images. There's physical ability or restraints also from being sexually active as well. So so many different parameters of life are simply affected by hernias. It's not just a 15 patient with abdominal hernias, and they were simply interviewed, and they took them transcripts, and what they found that after they took all the interviews, they looked at basically what how can classify the complaints from the patients, and they fell down to these 5 different body image. Some of these quotes because I thought they were very telling from this perspective, and I'm going to read these to you. But one felt like a burden I was carrying around, but the main burden of not being the pain of the condition, but the weight of what other things. I think that's a powerful statement, right? So it's not another quote. I think that the biggest issue is I feel like Mr. Blobby, or Jar Jar Binks. I'm a Star Wars fan, so I threw that I've got that many lumps and bumps now. I'm just like an elephant man. So these are very telling quotes. You know, this really affects their mental being, specific mental health. There's 6 grandchildren, causing him to fear their memories of him as a son. I mean, that's sad. All right. So I think how this can really be traumatic for a lot of patients. So we do here, coming to this conference, learning about this stuff. We're not sitting here as like we're really in all on you're affecting not only lives but their family, right? So it's really a significant extent. Symptoms, I've had a couple of other occasions when I woke up in the night sweating with pain. It was excruciating. Interpersonal relationships, intimate sexual relationships were negatively affected by abdominal wall hurt. You tend not to look at your, not allowed to look at me anymore. Employment. I unfortunately lost jobs because of it, because it keep me on long time sick. So, this kind of sets the stage here in terms of what we're trying to do and what we're doing, because it is such a traumatic approach. Just ensure patients are aware of individual risks, benefits of intervention. Critical that surgeons understand how patients' hernia affects their quality. So when you meet these patients in your offices and you have conversations, life really does come in play. I mean, I can speak personally in terms of what I had conversations about, hey, these are types of repairs that meshes boundary of evolution in terms of what we're doing in the world of hernia. There's different types. You got permanent, you got bioabsorbable, you got biologics. What are they? What did they feel about the mesh? These conversations are, you want to start to make the patient become active in that conversation of surgery is going. I have this instance of those all the time. I always tell them, look at the studies that are being published, because you're going to see where the trends are. You're going to understand what's important to physicians, surgeons, and what's important to patients. So again, some specifics. These are a lot of specifics. These are a lot of studies are previously published. One of these, but a little bit later. Hernia recurrence. The blue line is no recurrence. You feel status in these patients, and their quality of life measures, and you follow them. Even patients who had a hernia recurrence, these are all comers recurrence. But if you look at their quality of life, even for those patients who had some of their quality of life measures were still higher, even after office. You take them to the OR, you fix them 5 years, 10 years later, they come back and make their defect. Okay? If you have a conversation with them, still functional, their quality of life is vastly improved. Most patients can easily tolerate a 2 centimeter defect. So by definition, failure, we've had a recurrence. Our current standard probably no. Gave functionality back to the. At the end of the day, that patient had a my eyes. Okay. So I thought this graph was very telling. And again, I just want to point out a lot of these studies now. You can see there's so much information that's focused on quality of life, and I think when we talk about outcomes for patients, we talking about the function of their day-to-day activities. Here, this is a simple activity. I just went to quality of life and hernia repair, and you can see the exponential in quality of life measures in the world of hernia. I hope in a year or two from now, we're not going to be in the midst of hernia repair. Quality of life needs to become a really effective at what we do, and not just recurrences, and not just the complex. So there's going to hopefully be a shift in the balance of hernia outcome. Currently, our main outcome is really recurrence, right? So focus on recurrence. So in reality, there's got to be other considerations. All right, so some citations, and thank you so much. Hopefully this is a nice little introduction. So sorry, Dr. Gamble slash McDonald couldn't be here, but that's it. So I want to hand over the floor to more time from them and if you want to introduce the next one. So appreciate everybody's time. So Dr. Hook will be with us. So we're gonna play his lecture for you guys.
A review. However, morning. My name is Hobart Harris. I'd like members of the program committee for the invitation to participate in this Quality of Life grading scales. During my brief presentation, I will go over definitions of quality of life, discuss various tools that have been applied to patients undergoing care, show some of the more frequent. So, what is quality of life? And well, the World Health Organization defines quality as an individual's perception of their position in the context of the culture and value systems in which and in relation to those of the Quality of Research Institute at the University of Toronto. It's the degree to which a person enjoys the importance of his or her life. However, for those of us in healthcare, quality of life is on an individual level. With that in mind, why it's important by surgery. Well, there are several reasons why quality of life is important in surgeries. First and foremost, patient evaluating the effectiveness of a treatment can be in quality of life. Quality of life measures can be indicator of a higher risk of complications. Use quality measures as a way of determining clinical efficacy. And finally, assessing the effectiveness of the care system. Well, as you can tell, quality of life assessment largely qualitative endeavor. Quality of life, one can look at a variety of assessment domains. You can look at it in the activities of daily living, for work, or participate in recreational activities as they would are in pain. One can look at the psychological health. Is the patient anxious or experiencing depression? Or you can look at social relationships. Certain characteristics, however, are shared by tools. They are by and large validated. They involve patient self-reporting. They support the engagement of mixed methods research. And there is no single standardized tool. For the purposes of this morning's presentation, life assessment tools can be subdivided into types. They can be either generic or hernia specific. In this table, we do 12 different patients follow hernia repair. As you can see on the generic life assessment tools include the most well-known of quality of life tools, Form 36. On the hernia-specific quality of life survey, the Hercules comfort scale. While it would not be practical over each of these 12 assessments in granular detail, what I've attempted is the top 6 scoring systems specific, whereas the lower 6 for general health status assessment or merit. Note that there are 4 potentials covered by these various assessment tools: pain, mental health and/or patient perceptions and/or symptoms. You will note that the current quality of life survey or Hercules, along with the abdominal hair, evaluate patients across all 4. Whereas similarly, the general health status quality of life assessment tools focus on ABLs, pain, and mental health. None of the generic tools focusing on secondaries. Now, of course, the questions for the hernia specific are this, that, or its repair on these domains. All of these different assessment tools, one might reasonably which ones are used most frequently. Fortunately, there was a very nice review article published at University of Rochester, and in that they provide the overall use of patient outcome tool wall reconstruction. As you can see here in the graph, the most commonly used tool is SF36. Therefore, it the most commonly used generic and hernia specific when evaluating patients following reconstruction. While we don't want to get too deep in the weeds, I think it would be useful generic and hernia specific narratives, just so you get a flavor for what reports and patients are answering. So here you can see short form 36. The first question is, say your health is, and a patient would rate it 1 to now to a year ago. Other questions might ask them to rate various activities, having a lot of limitations to no limitations at all. Activities such as several flights of stairs, or bending, all straightforward and easily answered questions your patient. Comparison, here is the hernia-related quality of life Hercules. As you will note, the S6 has 36 questions, are scoring these questions from 1 to 6, with 1 being strongly disagree to 6 representing a agree. The questions are things such as abdominal wall causes me physical pain. My abdominal appears because of my abdominal wall. Words are then transformed to a 0 to 1 scale with a with a higher score representing increased quality of life. In this particular study, the investigators demonstrated that for 88 mean score of 62, 6 months post. I would I would have you also note that is the most commonly used hernia specific assessment tool and is becoming increasingly popular in the literature. They are living their best life. Quality of life patient's choice of treatment, the perceived effectiveness of it, and inform the overall quality of healthcare being delivered. Quality of life assessment tools can also be either more hernia specific tools. Your attention.
It was a great talk. We're sorry, Dr. Harris couldn't make it today. Our next speaker will be presenting on the implementation of quality of in central hernia repairs.
Good morning. Thanks everyone for having me. But I did serve on the ACHQC board for 3 years. I am also director of surgical services and hernia center at the University in Seattle. So must disclose. Okay, let's talk about quality is a big buzzword in the past 10 years or so. Hospitals are really focusing on this. So it's an overlap of satisfaction and empowerment. Some nice definitions of quality of life, but I wanted to show that it really encompass quality of life are ability to have some control and over their life to find their value. So as far as how we look at quality of life, sort of assessment, and patient reported outcomes. Call this information gathering. In our hernias, we start with a preoperative assessment, the ACHQC, and this is first of all there are 3 assessment tools: a combination of a pain scale and understanding if they were taking any narcotic. Hercules, looking at the psyche activities of daily living, and the EuroH adds the addition of form and ease of giving out the form reading area. We just use the combined one. So prior to entering the patient, we're really focusing on looking at reviewing the life measure. Now, you may have patients similar to this. My demographics may be a little bit different because we have a slightly healthier population in Seattle. A lot of people come because their PCPs. I don't know if you all have this, but electronic medical record get their results before we see them. and they can also review their own. So they read their imaging report. I have a hernia. They get worried. They go to an emergency. Some patients actually have pain. Did multiple times for bowel obstruction and don't want to have another. They may have a non-healing wound, or they just don't like the way it. So next is really understanding, want them satisfied with their visit. Just want reassurance. Can they die from their hernia or get a clot? Some want to look better. Some people have so many problems. They have a problem with control over their life. So they have this small umbilical hernia, which is the iceberg. But then, so to remember that patients need help. Patients with complex abdominal wall hernias and through major trauma. They have terrible outcomes with surgery. Their families have PTSD. They've seen multiple other surgeons. There's no one out there to help them, and they just someone to listen to them. And that's where you need time to meet them where they are. So that's where you really have to get their buy-in and really about what is their current quality of life, what was their quality of life, and what are their hopes of improvement. Do they want to get back to play golf again, like young males did after a time and go out to dinner with them? What are acceptable improvements? And how likely are we to accept? Of course, looking at comorbidities and for using whatever online calculators you like to use. Let's see, rail tree. What type of surgery are we going to choose? Do they need to be medically optimized? And if they need to be medically optimized, what resources do for that? Are they able to the weight or get access to medically supervised weight loss? Are they in so much pain that they can't actually exercise at all? Don't have the to be able to financially support a gym or personal trainer? You need to give them weight, and then you need to decide what is the best repair. So, in mind, who owned a house cleaning business, she found her business because she couldn't participate. Yes, her BMI a little bit higher than I would have liked. She had a BMI of 42. Great after an open TAR and was back to function business. In need of surgery? No, needs a surgery. Last week I saw a 40-year-old male with colon cancer on his third line of chemotherapy, liver mets, whose oncologist sent him incisional hernia. It was asymptomatic, but get into it. This guy likes to exercise weightless. He came to me tremulous that I was going to offer him an operation. And what's your goal? What's your goals of care here? What do you visit? And he said, Dr. White, all women be ready for ski season. I mean, what would I tell this patient who's clearly going to die in the next year? You don't have to avoid heavy lifting. So I gift by not operating on him and creating his fear of here. And I'm not sure I can play this video. Oh, there. Okay, so this is a patient. I want to know what you do. 6 retired school principal with compensated alcohol induced daily pain, but takes Tylenol. Unable to clean garden, but most importantly, she's had 2 admissions for incarcerated hernias. Her MELD score is 8. Thrombocytopenia. He was referred from a hospital about 4 hours away because everyone was scared to fix her. And I'm just gonna let me go back. Well, I don't the giant abdominal wall sees. If you see how big they are? Okay, small hernia in it, giant varices in the field. So what it optimized her meaning that we made sure she didn't, her platelets were 49K, gave her platelets on the way back. A open incisional hernia with a mesh suture. She was back to line dancing 2 weeks later. Went home the same day. She didn't and she did really well. And her family was really thankful. I want to thank you. Coming from Seattle. I find your value in life and do it for a living. That's what I do as a surgeon. I think that's what we all do as and every day.
Paul, if you want to stay up. Yeah, hopefully it's for some questions. Thank you so much. This is Dr. Philip Moisems from Hillary from again to Belgium, significant leader in hernia and over in the entire Europe. He sat on many boards, past, present Europe as well, and thanks for coming to hang out with us. We appreciate it.
Thanks for having me and for being invited in quality of life measurement session. Which so these are my disclosures. Quite some reason important for this talk, which is going to be about implementing quality of life measures. So first, how did we develop? The primary reason why I'm on this podium now is because UHS quality of now 12 years ago, we started to create a registry. And of course, you want registry, you want to have definitions, and some of these pictures you might, because they've become very popular. And part of this was some publications, the classification, which is now going most included developing a quality of life score. Recommendations like how you would report your outcome. Look at why is it so difficult to track and to compare different operations or different patient populations, because there's so much in your patients. As you know, there's a patient, there's outcomes that you should measure, complications, quality recurrence, and as we heard before, recurrence is low, and sometimes the recurrence can still quite an improvement compared to the preoperative status, although it will be considered a failure. It's actually to have a baseline, and you get to it post-operatively, and you do that several moments of the follow-up. There's a domain in pain. There's a domain in restriction of activities with and cosmetic discomfort. So the pain would be 30. So the largest overall score is 90. The higher the score, the worse your quality of life is. So we validated this score in a study of 100 patients using a laparoscopic TAPP pair. This is how we published it, but of course, and this is to have a translation actually in the actual language of the individual. You know, in Europe there are 27 languages. So the one that we used in this study specifically because this study was done Dutch speaking part of Belgium. What we compare? We compared what is called the verbal rate. We were thinking about introducing the scale in our hernia, but it was licensed. We actually had to pay for it. And also the thing is that because a lot of the questions are of the mesh, and obviously normally you don't have a surgery. Actually, assessment is very important. This is just the outcome and probably that we had. Of course, this is a table of numbers. It's not spectacular, but the nice thing about this study is that we really see that we do have an impact, at least considering this, even of the three level of the hernia quality of life. And that even improves after up to 1 year. It was quite amazing results to see that. So we did. I don't understand everything of it, but you need internal consistency, retest. So we tested at 12 months at least. We had a project to validate for ventral hernia, but ended up anywhere because of time and some studies start and don't get a final result. Is it implemented in registry? So we put it in our REGCHAS. URHS has never been really Europe, but been like the foundation actually for many of the other databases to use the data that we created actually sets that we create like the classification, things like that, and also the American Hernia Society quality collabs that came up changed into the EHS, which you can enter. You have to be a member of EHS, but for the rest, free of use. And this is the way we introduce our quality of life. As you see, you have several languages there, and I'm quite proud actually that also the champion register. How is it used in studies? I will run over a little bit of the studies that I found that used to score mainly. Yes, this was the topic of my talk. We're not going into detail. What was the result of all these studies, but just to show how data can be used and presented. If you have small groups like in a number of cases, if you have bigger cases group study from Germany, you can find actually result representative and also become statistically in some cases. So this is comparing patient pain versus patient with no pain. Can't see it. It's too small. Actually decided that the aesthetic component was not important for them, so they just using a restriction of activity domain, which I think still for groin hernia, and you will see in some studies that also for groin hernia the component can be quite different types of approach, like TF Liechtenstein in this Brazilian study. And this is a study of 30-day outcome of different ways to but you can use it for to find out which is actually leading to the least pain. Another which is using it now, and I was very pleased to see that significant numbers are there, and this is the nice thing. Once in a registry, it's commonly used, and you get a high number that come out, like here, whether you check for one nerve, two, three nerves. Uh, Apparently, there's a trend. Some people comparing it to Schuldeis, compared to Liechtenstein. If actually favorable is somewhat new technique, where you fix permanent sutures. Question is how resolved. We put it usually on paper. You can also send it via email or on paper. This is looking at how a smartphone application could get your feedback. Actually, in our registries, we have a link where you can actually send to the patient and get. But of course, you need your patients to be a certain level of expertise, knowing how to use the and so how you report the results. We didn't really find that when we created the score. It make in the very spectacular. We used line chart for some of our for our patient group. This is not or is similar. This is another way you can present some standard deviation. You can use box and whiskers or those bar charts. This is a study that we did, and we looked actually. We can have a habit of using one mesh for bilateral groin hernias. A bit worried about urological that might occur. So we and with this bar charts. Another way to present it. It's too many papers actually go into detail. One paper that I would like to discuss a bit more. I'm quite happy with having found this paper now is that they decided to do a study because numbers are still important difference. It's a whole methodology described. You should read the paper. I didn't understand every detail of it, but you end up with in the score for pain it's 3, for restriction it's 5, which is considered like clinically specialist. The way they presented the data, I probably have to find some authors if they are here. Please explain me how it works. It looks a bit like the towers you have here, which are the charts that you can have. And I created a while ago. It never took off. Looked quite fancy. The hernia outcome quality index. Of course, it's not only quality of life. It's also important to recurrent medications, and I think that you could actually work when the audience want to do that. The level of impact of a certain complication or recurrence, or the quality of life score. And I quite like the name Hawkeye actually. Okay, I've never been to Chicago before. I was here on Sunday, so I spent a few days. Very can do a comparative study there. They're very nice cocktails, but the only thing is, we're Europeans, we really don't drink cocktails from plastic. So please come to Paris, and I think Johan Renard would be very offended if you would drink his do that. Give us glasses. Thank you.
Thank you. Our next will be given by Dr. John Fisher, who is a professor of the Division of Plastic Surgery at the University of Hernia Outcomes.
Good morning. All right. Good morning, everyone. Really a pleasure to be here. This is going to kind of build on the talk I gave yesterday, focused on quality of life, patient-reported outcomes, and kind of measure the impact in practice aspect of what we do. And some things resonated with me. Dr. Boyd commenting that we begin where we're starting from to know where we ultimately, listening to your patients, right? Listening and understanding, asking thoughtful questions that help you gain insight. And before I start, I can't help but make a couple kind of about Dr. Harris's talk. I mean, an absolutely incredible review. Like the one thing that I think that got overlooked, and Philip mentioned this, is the validity of an and so these instruments that you're seeing take a science, and I think that when you look at an instrument and you contemplate in your practices to measure outcomes in your patients, you have to make sure that instrument really captures voice. And so significant qualitative work happened to gather that information, a response to treatment or characterizes outcomes. And my only other comment is an outstanding instrument, and I think it is actually very much valid and has face validity. That instrument was developed by surgeons and Mike's group, and I think it's a very accurate, but it doesn't capture in this area where we've done focus group patients, developed an instrument, psychometrically test the alpha Cronenberg measurement, done test run prospective evaluation, and I just wanted to kind of there. We're obviously very proud of the work that we've done here in front of me now. It's obviously something I actually care about. So quality of life and recurrence, future of the outcomes. I think PROs have to be part of it. I think the last talk that we just saw captures that concept perfectly in that dimensional, very complex problem. When you add in patient-reported outcomes, create a multi-dimensional picture of what's going on. And I think that's what we care about. So the answer is yes. Part of what we do. These are all of my disclosures. So from because I think that this I think is involved where you have some discordance between outcomes and patient-defined outcomes. And here's the perfect example, and Sal hit the nail on the head literally perfectly. You have a massive hernia. You fix it. Patient has a failure. Okay, I don't see any hands. So I mean, the point is that we have to understand where we're starting. We have thoughtfully, and this data from the Rosen group and their whole team doing phenomenal research. Obviously, I just wish that they were using the abdominal post like the Hercules. 5%. That's probably not totally the whole story. That's a definition in part extracted by radiographics of patients, clinician defined recurrence, and also reported which I don't think is an appropriate rarely measure a clinical outcome by asking it, is it despite occurrence, either patient defined or radiographically, patients had less pain, and better quality of life, which I think is fascinating. And so if we just cross that line out, and this is not good work. But I think in reality, what we're talking about is patients, information into context. There's another, I think, amazing study, Michael Yang, who's in RCT, looking at whether or not you close the fascia palm, randomized control trial. Okay, so pretend that they didn't measure quality of life. This is a negative study. No difference in clinical outcomes. No difference in recurrence. However, they actually found that when the fascia was closed, patients had a significant higher quality of life post-operatively. It changed your perspective and your viewpoint about what this data in this study. So again, let the evidence to be that big front wheel. That'll control where you go, I think. Group published this, and we had a hypothesis that these complex patients that were, I'm not helping them. Lots of complications, long, protracted recovery, a primary ventral. You have a incisional, recurrent incisional, multiply recurrent incisional. Kind of, what is your delta in terms of quality of life? Where do you start? Where do you go? Our surprise, actually, everyone experienced significant cases, even though they suffer through some morbidity that we're obviously trying to reduce. They do derive a tremendous quality of life, and the reason why they do is their quality of life. If you write their quality of life on average starts much lower. If you have a 3 hernia, your quality of life at baseline is actually meaningful. So that's a way to question. This is data from Henneford's group. For having low PRO delta, or might actually be preoperative pain. And again, preoperative pain may beget post-op, and we should be thinking about things, making decisions, patients, listening, et cetera. I just want to Ben Paulus. Hobart's taught that maybe PROs can predict complications. Maybe, leading indicator. They've shown that complications are associated with lower of life, and so I think that's important. They do particularly so. Who knows if it's the truth or not? I'm just kidding. So this is church and state PROs to paint a full picture, right? Keep church. So missing the mark of the validity of the ventral hernia screening tool, and again, this was actually brought forward and referenced as an instrument to measure outcomes. And this is a series of questions basically used for you to screening tool. But I just want to kind of share with you how well it works. Okay, so what are the questions? If I can read them. You feel like your hernia is back. Has a physical told you your hernia is back? Do you have a bump? Do you have pain in your abdominal wall? So if any of those 68 ground label truth, we brought all these patients, and this has terribly positive predictive value. That means that if you say yes, I mean you have hernia, by clinical exam. Of course, a hernia is a client out keeping these concepts separate. Now, however, if you are are negative, that is, you say no to all options, it has very good negative NPV, meaning that if you say no, you don't have a hernia. It's still very useful as a screening tool to determine if you know how complex is the defect when we start about that. And again, this has already been brought up. What is the patient's baseline quality? Is the clinical outcome good? Do the PR, do they move in the right direction? Is the delta, direction? And I made this incredibly silly. A lab represents defects, and green is like they have, actually baseline quality of life, and red is they probably don't. So for each of these scenarios, you can have or no complications. You could have no delta in PRO. You could have a pull. If you fix as high preoperative quality of life, massive repair, they have a big hernia, you have lots of complications, quality of life goes down. I think we know the answer is maybe that was not what to do, or we should try to learn from that. So there's probably opportunity about this as a big puzzle. What are the right phenotypes to be operating on? I'll come over after my tirade here and my introduction here. Correlation between clinical and patient-reported outcomes to be used together to create a multidimensional picture of the total outcome. We have to really consider where patients are. There's different subsets and buckets where we can kind of look at them and understand, are we doing the right operations at the right patient for the right reason, and are we getting the right results? Thank you, guys.
Panel.
Yeah, so Dr. Fisher and Dr. both touched a little bit on validation of these, and just maybe if you could explain conceptually a subjective issue.
So there's quality of life scores and validate them. I think we did 12 years ago was like sit around the table and say, okay, that's what we think is important. I think realizing now what's important for them, and then score, that's a whole lot of work. And something that we spent, like, we have 27 languages, and even within one language, the Dutch in the Netherlands, they the same word, like, so certainly in America as well, they might, the British probably insert words. So if you want to really also the language, for example, elaborate process, you need a lot of time, research people to do that. If you want to really, very happy to see that it is used, and I think it's very important.
Yeah, I would agree with all that. I think the surgeons probably are not equipped, by ourselves to kind of develop these instruments. Certainly, we have some of the conti's. I think that instrument has to represent what matters to the patient, has to talk to the patients. To validate the instrument, I think qualitative research scientists, the psychometrician, you have to do the standard process. You generate items, you do item reduction, you do correlation, test it, how to do it per se, but we collaborate with, research experts to develop the instrument. The 8 years to develop and several $100,000 in institution. It was numerous focus groups. We looked at the hernia, the Hercules. We looked at the calculations, tips, telephonic interviews, used in vivo to pull out themes. Tested it. Just years and years of work, and I think actually is reflected in what's there. And going back to some of the comments about what instruments are available, and what is HQC, some aesthetic outcome measure. If you look at the items in the abdominal hernia queue, the first pain domain, the 7th and 8th question have with appearance preoperatively, scar quality, and the abdomen, and the postoperative questions encompass all those. So provider satisfaction to do with how they view you and perceive you. I'll stop.
We're kind of over time, but I have one really quick question for everybody. How do we get the U.S. to adopt these measures of a successful hernia outcome is not just a recurrence? Because we know it works, we know it's important, but especially across the U.S.
I think having this is one of the items that you get, like how you're going to get that administrative work. It's not always easy, and of course you cannot afterwards. You cannot say okay, if you missed one 3 months, you cannot say, oh, can you try to do it 2 months ago? So you need to actually be quiet. But having registered for you want.
We have the ACH QC database. And one of the biggest challenges with that is the data portion. So your institutions or your person needs to buy in and see that it's important for surgeons to all their own data could use that to lobby to the government, to insurance companies, and use it as a more powerful tool. It takes a lot of either institutional buy-in or first buy-in to take the time to put your data in.
I'll try to keep it brief and won't be sarcastic. Quality of life. I think the answer may not be in registry. You have to embed quality of life measurement into routine, but it doesn't interfere with what we do. And as an example, at Penn, it took only 3 years for us to work with Epic to get into our portal where if someone gets scheduled on their phone, and it will remind them at certain time points. And our capture rate wasn't good at first, but we've kind of dialed it down. It's going up. We're capturing 50, 60%. That sounds great, but it's better than zero, and we're capturing across the spectrum of people that are getting. I think in the end, that's probably the most effective. Where it's working in the background. It's not interfering with the surgeon interaction. It's not putting the burden on the surgeon. I think that's what we're doing. Yeah, that's what we're doing.